My patient is Mrs. XX, 68 years Hindu lady, resident of Kalighat and a homemaker from lower middle socioeconomic class, who presented with complaints of loss of appetite for last 7 months and pain in the right upper quadrant for the last 3 months. The patient was apparently well 7 months back when she developed loss of appetite, which was insidious in onset and progressively worsening. It was not associated with nausea, vomiting, or abdominal discomfort initially. This is associated with significant unintentional weight loss over the last 4 to 5 months. Around 3 months back, she developed intermittent episodes of right upper quadrant pain, which was colicky in nature, radiating to the back, precipitated after fatty meals, and relieved with analgesics. She reports 5 to 6 such episodes. Over the last 2 months, the pain has become continuous, dull aching, and localized to the right upper quadrant, aggravated by fatty food, and only partially relieved with analgesics. The pain was associated with anorexia, nausea, and occasional vomiting. There is no history of jaundice, fever, night sweats, hematemesis or melena, abdominal distension, or any altered bowel habits, or any respiratory symptoms, and there were no other features suggesting of any distant metastasis. The past history, the patient is not a known case of hypertension, diabetes mellitus, tuberculosis, and is not taking any medication regularly. There is no previous history of hospitalization or surgeries, no history of jaundice before this episode, no history of any blood transfusion. The patient is married. She has two children, one son and one daughter. Both are healthy. She takes mixed diet, no history of any addiction. Patient has a normal sleep pattern and her bowel and bladder habits are normal. Patient attained menarche at the age of 12 years and menopause at the age of 46 years. History of regular menses lasting around 4 to 5 days a month with normal flow. Uh, Patient's parents have deceased, uh, died of natural causes. Siblings, one male, 62-year old and in good health condition. No history of any cancer-related deaths in the family. So, this is a 68-year lady, apparently well 7 months back, who presented with insidious onset and progressively worsening anorexia followed by significant unintentional weight loss over the last 4 to 5 months. She subsequently developed intermittent right upper quadrant colicky pain, precipitated by fatty meals and relieved with analgesics suggestive of gallstone disease. Over the last 2 months, the pain has progressed to continuous dull aching type, localized to the right hypochondrium, and only partially relieved with analgesics, indicating a change in character. The pain is associated with nausea, occasional vomiting. There is no history of jaundice, fever, gastrointestinal bleeding, altered bowel habits, the abdominal distension or respiratory symptoms or any other features of distant metastasis. Past personal history and family history are non-contributory.
Okay, good. So that is a fairly detailed summary. So at this point, before starting examination, what are the possibilities that come to your mind?
Dr. Sourav, before one
Hmm.
thing, he used the term developed appetite loss, developed pain. So this English is not appropriate. You got my point. Nobody develops loss of appetite. Nobody develops pain. Patient experiences pain.
Yes.
Okay.
Okay.
So
Fair
instead of
point.
Okay.
saying develop pain, this term is little not appropriate for use in English in this context. Otherwise, history is well described and you covered almost everything. Fine, but just these two words should be changed. Yes.
Okay, sir. Thank you, sir.
Okay. Fair point.
Yes.
Use the word experience. That is better.
Yes, sir.
So
Yes.
what are the possibilities that come to your mind with this history of progressive anorexia and weight loss and upper abdominal pain, which was colicky first, and now it has become constant and more severe in intensity, right?
Yes, sir. Sir, considering the colicky nature of the pain in the right upper quadrant, which aggravated with fatty meals, we must think of a gallstone related or a chronic cholecystitis, but along with it, a longer history of loss of appetite and a history of significant weight loss over the last 4 to 5 months is suggestive of some neoplastic um growth in the gallbladder or any other, mostly gallbladder in the right upper quadrant.
Any other possibility?
Um,
Suppose
sir,
I say it's a renal stone.
yes, sir, it can be renal stone also, but the loss of weight is should not
Maybe
go
she's
hand in
developing
hand.
hydronephrosis. The stone has got lodged in the PU junction. Now there is hydronephrosis that is causing pain, and there is pain. There will be loss of appetite. When you're having a lot
Yes,
of
sir.
abdominal pain, nobody will like to eat. It's
Sir,
associated with nausea.
yes, sir, I missed that part of um, any urinary symptoms. I did not mention any urinary
That's
symptoms.
okay. You need not
Yes, sir.
mention that in symptoms. You have said there are no other significant symptoms, but in
Yes,
the
sir.
differential diagnosis, I keep saying this in all the classes, don't jump on the actual diagnosis.
Okay, sir.
Keep an open mind and force yourself to think of 2 or 3 other differential diagnoses, which have to be reasonably fitting. Don't
Mm,
say the sigmoid diverticulitis for right upper abdominal pain, but
mm.
whenever you are localizing to one quadrant, think of the other organs in that quadrant. Why not hepatitis? Intrahepatic lithiasis
Yes, sir.
after PSC or something like or RPC,
Yes, sir.
maybe RPC with intrahepatic lithiasis with
Mm,
atrophy or hypertrophy of liver that can
yes.
cause recurrent pain. So think of the organs which are there in that quadrant and think of some pathology in that quadrant which could also fit some. It will not fit perfectly, like the significant weight loss that you're saying. That should not
Yes,
occur
sir.
with a renal stone. There should not be
Yes, sir.
significant weight loss with renal stone. So it
Yes,
will
sir.
not be a perfect fit, but at least examiner will know that you have considered other possibilities.
Yes,
Okay,
sir.
And,
carry on.
second is patient is an elderly lady presenting with uh, gradual onset of weight loss, appetite loss, can be other upper GI malignancy, like
Yes,
Yes,
maybe
sir.
a carcinoma stomach or right
yes,
Yes,
colonic
exactly.
growth. Okay,
yes,
so
sir.
you should keep in this. You should not be very prefixed that uh, will be focusing on gallbladder cancer only.
Yes, sir.
Okay, carry on.
Sure.
Examination.
Yes. On general examination, the patient was examined after taking informed consent in a well lit room with proper exposure in the presence of a female attendant. The patient was conscious, alert, and cooperative. Her Karnofsky performance status was 80, average build, decubitus of choice, gait was normal, BMI was 27.5. There was no icterus cyanosis, clubbing, pallor, or generalized lymphadenopathy or edema. Neck veins were not engorged. Pulse rate was 88 beats per minute, regular normovolumic in right radial artery. Respiratory rate was 16 per minute. Blood pressure was 122 by 74 in the right arm in supine position. The temperature was 98.3 degree Fahrenheit. On abdominal examination, the abdomen is flat, umbilicus is normal and inverted and centrally placed. All quadrants move with equally with respiration. No localized fullness is noted. No scars or sinuses or pulsation or dilated veins noted. Bilateral hernial orifices are intact. Bilateral renal angle is free. On palpation, there is no local rise of temperature. Abdomen is soft with mild tenderness in the right hypochondrium. An approximately 5 by 4 centimeter lump is palpable around 2 centimeter below the right costal margin with ill-defined margins, and heart consistency. And sir, I changed it a bit. I think it did not get saved, and fingers could not be insinuated all around the lump. Liver and spleen are not enlarged, no other mass palpable, hernial orifices intact. No renal angle tenderness noted, no inguinal lymph node palpable. No, sir, here it was written.
Okay. Does it move with respiration?
Yes, sir. Sir, I have mentioned here, sir. It moves with
Oh, yes, yes,
respiration
yes,
and
yes.
fingers.
Sorry.
Actually, I changed the slide. I forgot to delete the previous ones.
It's okay.
On auscultation, normal vowel sounds heard. No added sounds or bruit heard in the whole of
Why do
the.
you skip percussion? Why do you skip percussion?
Uh, yes, sir. Sorry, sir. I skipped percussion.
Percussion. Okay. Liver span, free fluid.
Yes, yes, sir. Yes, sir.
So just tell the percussion findings orally. No need for slide.
Sir, on percussion, the
Here you should make out the liver span and the lump you are
liver
palpating
span
is
and the lump. Yes, sir. The lump had uh, was dull on percussion only, and the liver span was
The upper border of liver dullness was in
normal.
this position, so the span was no.
Normal, sir. Yes, sir.
So upper border is in which position normally? Which intercostal space? If the liver is not enlarged, the upper
Sir,
border of liver dullness in the
sir, if no, sir.
where it comes. In the mid clavicular, it is in the fifth intercostal space.
Fifth intercostal. Yes, sir. Fifth.
right fifth intercostal space in the mid clavicular line. You have to say that
Yes,
full
sir.
thing. That is normal. If it is pushed up, if the liver is
Yes,
enlarged,
sir.
then it might find it in the fourth space or even third space. And below, if you find it palpable, that
Yes,
will give you the span. If you cannot find it palpable
yes,
below
sir.
the costal arch and the upper border is in the fifth intercostal space, then the span is normal. Span is the length or width, whatever
Yeah.
you call it, width.
Yes,
Okay.
sir.
And what is the rest of the abdomen? What is the note over the rest of the abdomen? The lump is dull, you said. What about the rest of the abdomen?
So the rest of the abdomen, there was no significant
So what
uh,
is the note?
finding for it.
What is the normal note of the rest of the abdomen? You percuss the abdomen, no?
Yes, sir.
You should percuss all four quadrants at least.
Acha, the normal is tympanic, sir.
Tympanitic.
Tympanitic, sir. Yes, sir. Tympanic, sir.
Okay, good, fine.
Yes.
So the rest of the abdomen was tympanitic, but the lump was dull.
Dull, yes, sir.
Okay, fine. There was no specific band of resonance over the lump.
No, mm,
Okay,
no, sir.
fine,
No, sir.
fine. And auscultation you've already mentioned.
Yes, sir.
So other systems?
Sir, other systems were within normal limits.
Okay, I'm
So,
happy with that. Sir presented a class recently. I don't remember where. I was attending that class. Professor Shah presented a class where other system also, he said you can do all the detailed examinations in 5 minutes or 7 minutes, something like that. So I hope he will not ask for that now. I am happy with what you have presented. Carry on.
sir, coming to the final summary, a 68-year-old lady, apparently well 7 months back, presented with insidious onset and progressively worsening anorexia associated with significant unintentional weight loss over the last 4 to 5 months. She subsequently developed intermittent right upper quadrant colicky pain, precipitated by fatty meals and reduced with analgesic, suggestive of underlying gallstone disease. Over the last 2 months, the pain has progressed to continuous dull aching type, localized to right hypochondrium, and not completely relieved with analgesics, indicating a change in character. The pain is associated with nausea, occasional vomiting, and occasional vomiting. There is no history of gastrointestinal bleeding, bowel habits, abdominal distension, or respiratory symptoms, and no features suggestive of distant metastasis. Past personal and family history are non-contributory. On examination, the patient is hemodynamically stable with no pallor, icterus, lymphadenopathy, or edema. Per abdominal examination reveals a soft abdomen with mild tenderness in the right hypochondrium. A 5 by 4 centimeter lump is palpable in 2 centimeter below the right caudal margin, which is firm to hard in consistency with irregular surface and ill-defined margins, which moves with respiration, and one cannot get above or insinuate fingers around the lump. Liver and spleen are not separately palpable, and no other masses are noted.
Okay. So at the end of this, what is your provisional diagnosis now? Now that you've also examined the patient?
Um, Sir, considering the history of and loss of appetite and significant weight loss for 4 to 5 months, and the pain suggestive of gallstone pathology, and on examination, um, as we found a hard, palpable lump which moves with respiration, and we couldn't insinuate our fingers all around the uh, lump. Uh, it is suggestive of carcinoma of gallbladder.
I say it is an empyema of gallbladder. Recurrent gallstone disease leading to empyema of gallbladder. Will it fit?
Uh,
Why is it not
ye-
so?
yes, sir, but the unintentional weight loss is more suggestive of a of a malignancy.
Okay. Anything else?
Sir, it can be a
No, no. Why is it
mm,
not empyema? Anything else? Any other point?
oh yes, sir. Sir, there will be a associated repeated fever
Yes,
along
fever.
with
There is no
the
acute. Then why
no.
is it not? Why is it not pancreatitis? Chronic pancreatitis.
Um, Sir, in chronic pancreatitis, if it's chronic pancreatitis, there might be associated features of exocrine deficiency and endocrine deficiency in the form of type 2 diabetes mellitus or steatoria, and the pain will. Um,
What is steatoria?
Sir, I forgot the exact amount of fat in the.
No, that is
Um,
18 gram. Forget about it. Tell me what it is.
Sir, high amount of fat, voluminous stool with high amount of fat.
Which sticks to the pad. It sticks to the plant, which is
Yes, sir.
floating. Hmm.
Yes, sir.
Okay. Pale
And sir,
colored,
yes,
voluminous frothy stools which tend to stick to the pan. Yes, that is steatoria.
Uh,
Suggestive
Dr.
of
Ghosh,
fat malabsorption.
one thing regarding examination. At
yes, sir.
PG level, na, once
Yes, sir.
go to the examination part,
Yes,
abdominal
sir.
examination.
Yes, sir.
You see, once you come to palpation,
Yes, sir.
if you are satisfied that this lump has got a medial border, has got a lower and lateral border, moving with respiration, you cannot insinuate finger. At PG level, you can say that gallbladder is palpable this centimeter below the costal margin.
Yes,
Once
sir.
you say that, examiner can ask you why do you say this is a gallbladder mass. So
Okay,
once you start with this statement that gallbladder is palpable and the character of this is surface looks irregular and it's a very hard inconsistency, then it is implied that you are dealing with a gallbladder mass. Instead of
yes, sir.
till this point, you are not inferring that it is a gallbladder mass.
Yes, sir.
So what I'm trying to say is, in suppose you palpate the liver, so don't describe some linear structure is palpable in the hypochondriac, epigastric region, moving with respiration, surface is smooth. You straightway say liver is palpable. Dr.
Yes,
Ghosh,
sir.
what do you feel? How you should
Yes, yes,
describe?
sir. Yes, sir. I think in another previous class also you mentioned this. That was last year, I think. That at the postgraduate level, you can go ahead and say that it is a gallbladder lump. Fair enough.
Yes,
No,
And then
no
later
issues.
examiner asked, why do you say it is
Yeah, why
gallbladder
do you
lump?
say? Yes, yes. You can invite one question that way.
yes, sir.
And you can be ready with the answer. So before this, there's just one point in the general survey. You said KPS 80, no? Performance status was KPS 80.
Yes, sir.
Why is it not 70?
So the patient can perform her day-to-day life activities, not to his best,
In 90s also carries on normal day-to-day activities.
but with little difficulty. Like the anorexia is affecting her,
Now, what is
and
the difference between 90 and 80? 90 is patient has minor symptoms and signs of
mine.
the disease.
Yes,
80 is patient has major symptoms and signs. This patient has significant weight loss, patient is
yes,
having anorexia, and you find the gallbladder lump is palpable. So, major symptoms and signs of the disease. That takes the patient to 80. And if the patient still can carry out activity with effort, it's in the 80.
yes.
Okay, fair enough. So, why did you ask for jaundice? You said there is no history of jaundice. Why do you want jaundice in CA gallbladder?
Um, Sir, in advanced
How jaundice
disease,
may happen?
or if
How
the
jaundice may
neck
happen
is,
in patient's CA gallbladder? What are the different causes of jaundice in a patient who has got CA gallbladder?
sir, if the patient, if the if it is if it involves the neck, or if the patient has an associated disease syndrome, it might.
No, no. If it is in the neck, the
Yes,
presentation
sir.
of jaundice is early. Try to understand.
Hmm. Yes, sir.
If the tumor starts in the neck region,
Yes,
patient may have early jaundice in the course of disease.
yes, sir.
Other cause of jaundice in carcinoma gallbladder, suppose the tumor is in the fundus.
What is the more common site? Is it more common in the fundus or is it more common in the neck?
Sir, in the fundus, sir.
Yes.
What percentage of the gallbladder cancers start in the fundus?
Sir, percentage, I don't know, sir.
So most commonly around 60% in the
Yes.
fundus, around 30% in the body. So almost 80 to 90% occur in the fundus body region and only
Yeah.
10% occur in the neck region. Okay. But yes, if it occurs in the neck, then sometimes the presentation with jaundice is slightly early, like Sir said. Okay. So it may directly infiltrate into the common hepatic duct
Whenever TikTok.
and obstruct it.
Yes.
What else? Any other possibility that Sir is asking?
Tumor in the fundus. How the patient will have jaundice?
Sir, if it is an advanced disease, it might
How?
infiltrate the porta
So
and
that you have already said. That mechanism
yes,
that
sir.
the tumor itself is infiltrating the porta is
Porta, yes, sir.
accepted. That is accepted. Yes, it can happen. But the tumor is not infiltrating the porta. It is an advanced disease in the fundus. It is infiltrating the liver, but the patient is having jaundice. Why?
Many patient comes with jaundice.
Two other possibilities. You have to say.
Lymph
So
node.
the lymph nodes in
Yes.
the
Yes.
uh,
Lymph
Yes.
nodes around the perichoidal lymph node, they will be enlarged and they can compress. Very
enlarged,
often
yes, sir.
find it.
Yes.
So the
Yes,
primary growth is not infiltrating, but lymph nodal mass around the porta is compressing the porta. That is the second possibility. What else? Quickly.
And if there is extensive disease in the liver,
Yes,
yes, sir.
multiple
Sir,
liver mets. That
yes,
is
sir.
not
But
common, but it can
like
happen.
if two-third of the liver is involved, then
yes,
jaundice might
one or
Significant
two
develop.
amount of liver
metastasis.
involved.
Yes,
Sometimes
sir.
you do see in our country patients present
Yes,
so late. Sometimes you see multiple liver metastases.
yes, sir.
Not unusual. Every 6 months, 8 months, we see one patient like.
Mm.
Okay, so that patient may also have jaundice, but obviously that will be a different type of jaundice. That will not be obstructive jaundice. That will be more like hepatocellular, a mixed type of jaundice because of
Yes,
destruction of the liver parenchyma.
yes, sir.
Okay, so that is why jaundice is a very important history, but this patient did not have it. Okay, and
Mm.
rarely you might even argue that because gallbladder cancer is often associated with gallstones, a gallstone may have slipped into the
Gallstone.
common bile duct, and that might be causing a transient jaundice. So that there might be a brief history of jaundice and then it went away. That might be because a stone passed into the common bile duct. What percentage of gallbladder cancer is associated with gallstones?
Sir, around 80%, sir.
80 to 90% of gallbladder cancer
Mm.
associated with gallstone. What percentage of gallstone disease have gallbladder cancer?
Sir, 5 to 10%, sir.
No, not so much. No. Gallbladder cancer is so common. Gallbladder stone is so common. You are
Sorry, sir.
operating gallstone every day. 10% means 1 in 10. So 1 in
Yes,
10
sir. No, no,
gallstones
no,
that you
no,
operate
no.
comes out to be CA.
No,
No,
much
sir.
less.
No.
0.5 to 2% in various series.
100.
Some people have 0.5 and some people say 1%.
Yeah.
Like
Yes.
if you do 100 gallbladders, you will find that one will be Cancer. One will turn
Yes.
out to be cancer. Okay,
Sorry, sir.
no issues. Then what are the other important factors in the etiology? They are not really obvious in the history, but what are the factors that are related to etiology? One thing you have said, one factor is obvious here in
Sir,
gallbladder cancer. What is that?
the epidemiological factor of
Yes.
where the patient belongs is also very important, sir.
So, okay, so gallbladder, I mean, West Bengal is in India. So, does India have a high incidence or a low incidence?
Yes, sir. Then Gangetic belt is
Gangetic West, northern
known.
India, northeastern
Yes, sir.
India, it's high incidence area. So, that
Yes.
fits. Anything else?
Um,
Another point in the demography.
uh,
Lady, no, not man.
sir, females,
Gallbladder cancer is twice
females are
as
more
common in females as in
prone to gallbladder cancer,
males.
sir. Yes.
So, okay, so that also fits. What else?
Yes, sir.
Other etiological factors which may not be obvious in the history. Risk factors, etiological factors, associations. This is a theory question.
Sir, there are few genetic predispositions to the gallbladder cancer.
Like,
Sir, like, sir, sir, I forgot. P53 was one of them. P53 and
that is a mutation. It is a
KRAS
specific mutation.
mutation. Yes, sir.
The polyposis syndromes. Polyposis
Polyposis,
syndromes
yes,
are
sir. Sorry, sir. Yes, sir.
associated with the
Polyposis
associated.
syndromes
But
are
something more important, specific etiology of gallbladder cancer.
uh,
One is gallstone. We have
one
mentioned.
is
Anything else?
gallstone. Sir, adenomatous polyps of the gallbladder.
Any size adenomatous polyp?
No, sir. More than 10 centimeters, sir. More than 10
No, 10
centimeter or
millimeter,
multiple.
Millimeter.
not 10 centimeter, Baba. 10 centimeters is
Oh, sorry,
huge.
10 millimeters. Sorry.
So
Sorry,
1
sir, sorry.
centimeter. So
1
larger
centimeter.
polyps, especially more, the cutoff is 10 millimeter or 1 centimeter.
10
Yes,
millimeter.
then what else? Gallbladder polyp. But
Uh,
you will not get a clear cut history of a small polyp. You might just
uh,
get vague upper abdominal pain, gallbladder dyskinesia. What else?
sir, mm, sir, adenomyosis of the gallbladder, sir, porcelain gallbladder.
Porcelain gallbladder. Okay, what
Yes,
is
sir.
porcelain gallbladder? Quickly.
Sir, diffuse calcification of the wall of the gallbladder.
It is
Uh,
associated with the increased inflammation and risk of
yes.
gallbladder cancer. Yes, what else?
Um, sir, some infections by Salmonella typhi,
Very good. Then what else?
previous
Yes, yes, very
infection.
agreed. Next, what else?
Chronic
And
typhoid carriers. Yes.
yes, sir.
Any relation with the pancreatic duct junction with the
Yes, sir.
biliary
Yes, sir. Abnormal pancreaticobiliary junction can lead to gallbladder cancer, sir.
what is
Okay,
the
very,
explanation?
Sir, because of abnormal pancreaticobiliary junction, there might be reflux of the pancreatic um,
juice and the activated
juice
bile back into the
into
yeast.
the yes, sir. Yes, sir.
Bile duct or gallbladder mucosa, and that is not used to handling that. That can lead to chronic inflammation. The
Yes, sir.
clear-cut etiology of gallbladder cancer is unknown, but the prevalent theory, accepted theory, is that it is due to chronic infection, leading
Yes.
to hyperplasia, dysplasia, and then malignancy.
Yes.
Okay. What else? What else?
Sir,
How about choledochal
few
cysts?
yes, sir. Political cysts, sir, due to because of the same abnormal
These causes
pancreaticobiliary
you have to come
junction.
up rapidly. 1, 2, 3, 4, 5, 6. At least you should not have to wait.
Sclerosing
Any
cholangitis.
primary sclerosing cholangitis, PSC?
Primary sclerosing cholangitis also.
Yes. Then helicobacterial infections.
Yes, sir.
So all these things you have to mention. Okay. So you must not miss APPJ. You must not miss choledochal cyst. You must not miss porcelain gallbladder. You must not miss Salmonella typhi chronic infection. Okay. And polyps. Polyps first of all. And gallstones, obviously, 90, like you said, 80 to 90% of all gallbladder cancers are associated with gallstones. So that is very, very important.
Mm.
Good. So these are the points in the history and examination. I think you've covered everything. The important point is if the mass is palpable, it is generally an advanced disease. There is jaundice you have to look for. It will be obstructive type of jaundice generally. So now what will you do? So this is a suspect. This is a patient has come to you in the OPD. You have examined, and now you think that this is a palpable gallbladder mass associated with recurrent pain, which is becoming constant now. Weight loss, anorexia. The diagnosis is quite clear. What to do to confirm it? FNAC?
Uh, no,
Lump
sir.
is there. No
Not
FNAC.
FNAC.
Why?
Mm. Sir, FNAC only in
Look at
advanced
biopsy.
disease, sir, where we are not planning any resection, and we are,
Why? Why? Why?
sir, because the gallbladder cancer has a very is it's prone to spillage,
Spread along the needle
spread
tract.
along the tract,
Other forms of spread. Other forms of spread of gallbladder cancer. Quickly.
sir, the lymphatic spread,
Where? Which nodes?
sir, the peridocal, peripancreatic,
Pericholedochal.
sorry, pericholedochal, peripancreatic, hilar lymph nodes,
Peripancreatic is
and
later. Before pericholedochal, I mean, along with pericholedochal,
sir, hilar lymph nodes.
which hilar?
Mm, Sir, the periportal
Liver
lymph node.
hilum. Liver hilum, pota.
Mm,
So that is the pericholedochal. And what else?
Sir,
There are lymph
peripan.
nodes around the bile duct, lymph nodes around the hepatic artery, lymph nodes around
And
the
the
portal
portal
vein.
vein.
Yes, sir.
So all
Periportal,
the nodes in the
periportal.
hepatoduodenal ligament.
Yes, sir. Hepatoduodenal ligament, sir. Yes, sir.
Hmm.
Along the
Then
hepatoduodenal.
you go to the red
And then,
block or posterior pancreaticoduodenal.
yes,
And along the root of the celiac artery, root of the SMA also. Origin
Yes,
of the SMA, origin of the celiac. Along the hepatic artery, it will go up to the celiac. These are
yes,
the later, second echelon nodes.
yes, sir.
And then, of
Sir,
course, it will go to the retroperitoneal
pericable
nodes,
and
frankly, that
periaortic.
is a 16B.
Yes, sir. Periportal and.
Okay, what else? This is lymphatic spread. You have said spread along the needle track. What else?
Sir, there can be direct spread into the surrounding viscera.
Contiguous spread. Yes, agreed.
Yes.
What else? Contiguous spread to
Yes.
all the surrounding organs. That
Uh,
will influence the
and
staging, isn't it? We'll come to staging after this.
yes, sir. There might be peritoneal
Yes, it has a
spread,
propensity for peritoneal
peritoneal spread,
seeding. Yes.
and
Then
and
don't miss blood
and
spread.
my and hematogenous spread. Yes, sir.
how
Definitely.
hematogenous spread where?
Sir, into the lungs and
Lung is
Pass to
later.
the
the
Before
liver.
that, before
liver.
that.
First is liver. First is liver,
Hmm.
and then
How to the
lungs.
liver? How to the liver? Through the portal vein.
Sorry, sir.
Through the portal vein. Going to the liver through the portal vein.
Mm,
There are small, you are doing cholecystectomy regularly, Baba. When you are taking it off the liver bed, sometimes you see one or two small bleeding spots, no? And then you
yes,
can
sir.
coagulate them. So
Yes, sir.
that is
Yes, sir.
because there are directly small veins going from the gallbladder into the liver in the GB fossa, not going
Yes.
into the portal. It is, of course, going to portal vein also, but directly some veins go into the liver.
Yeah.
And through these veins, metastasis can also occur into the liver early in the disease. Once it has gone to beyond the muscular core, these veins can be accessed and you can get small mets in the liver bed, adjacent liver bed, which are what segments are those?
Sorry, sir.
The adjacent liver bed, the gallbladder fossa is composed of which segment?
Sir, for 4B and 5, sir.
4B and 5. So you
Yes.
can get, that is how you can get hematogenous spread. And other than that, it can go through the portal vein and through systemic veins, it can go to the lung. The most common extrahepatic or extra
Lung.
abdominal organ that can be affected is the lung. But generally,
Yes.
the major manifestation of distant metastasis are within the abdomen. Okay.
Yes.
It is rare to have lung mets without having extensive abdominal disease.
Yes.
Okay. So that is the spread. Come to the staging quickly.
Yes,
Or
sir.
tell me the invest first. Tell me the man. Let's complete the management first. Staging is purely theory question. What
Yeah.
will you do now? So you have said I will not do FNAC until I am sure that it is locally advanced and not resectable. Till then, I will not do FNAC. I will not do biopsy. So what will you do?
Sir, we base it mostly on the radiological investigation. We will do a contrast enhanced CT
Arey,
scan.
ultrasound, you cannot miss.
Sir,
Hmm.
first we will do an
Ultrasound
ultrasound.
is an extension of
Yes.
clinical examination. You cannot miss
Yes,
So,
it.
sir.
so you say, sir, the patient came with the
Yes,
ultrasound
sir.
examination. What did the ultrasound show?
Yeah.
Sir, ultrasound will might
The GP has
show.
already done ultrasound.
Yes, sir. So the ultrasound might show gallstones along with irregular thickening of the
Very good. Asymmetric thickening
wall,
of the gallbladder
asymmetric
wall.
of the wall, gallbladder wall.
So that is very early stage. Now this patient is having weight loss and chronic pain, constant pain, which is severe. Will there just be an asymmetric thickening of the gallbladder wall? You can feel the mass. So what will be the finding?
ultrasound is a very good investigation. You can find the cleavage between the gallbladder wall and the liver.
Yes, sir.
So you will often find that they comment that this fat plane between the gallbladder
The
and the
fat
liver
plane
is
might be
lost.
lost, sir.
Yes, blood or
The
lost.
fat plane might be
Okay.
blurred. Yes,
And
sir.
the entire gallbladder is replaced by a irregular heterogeneous echogenicity mass because you are getting a 5 centimeter lump palpable. So this is
Yes,
not a small asymmetric thickening of the gallbladder wall.
Yes.
This is
yes,
much bigger. The entire lumen will be replaced by a mass which will be composed of sludge and stones and the growth. Okay.
yes.
What are the morphological forms of gallbladder cancer? Again, a pure theory question. Or does it have any implication?
Gross type.
Like in stomach, you have the Borman classification,
Yes, sir.
infiltrative, ulcerative. In gallbladder cancer, what are the types?
Sir, don't know, sir.
So the most common one is this, the one that is the infiltrative lesion, which starts as a localized thickening of the gallbladder wall and then gradually spreads and tends to involve the whole gallbladder, involves the liver, infiltrative form. Then there is a nodular form. This is also pretty aggressive. It grows and it penetrates the gallbladder wall early, but it is not so infiltrative. So it may be locally advanced, but it is localized. So sometimes surgical cure is better in a nodular form because the margins are well defined. And the third type, which is uncommon, but which is still there, is the papillary type.
Papillary.
Papillary type has got a very good prognosis. So it tends to grow intraluminally. It does not penetrate the wall so easily. So you might get a large, the entire gallbladder lumen is occupied by this growth, but liver infiltration and nodal metastases are much less. So if you are lucky enough or your patient is lucky enough to have this papillary type, you might get a lump, but the stage will still be early stage and the chances of cure are much higher than the infiltrative or the nodular variety. Okay.
Yes,
The commonest is the infiltrative type of, this is a gross morphology. So
yes.
histologically, they are obviously most commonly, hello,
Sir,
Dr. Sourav,
nodulars.
No, no, histological.
histologically,
Oh, sorry. Sir, adenocarcinoma.
Yes.
adenocarcinoma. Any
Adenocarcinoma.
other
Yes.
possibilities? Just for
Uh,
completion's sake.
sir, squamous cell carcinoma might
Yes,
be
squamous
there.
carcinoma
Yes.
can occur because of squamous metaplasia, because of chronic
Yes, sir.
irritation by stones or infection, sclerosing
Yes.
cholangitis. What else?
Uh,
You can get adenosquamous, you can get lymphomas, you
adenosine.
can get some sarcomas. Sometimes rarely sarcomas can involve the gallbladder, reported, but very, very rare. Forget about it. Now, so you said you will do a CT scan. I agree. Contrast CT. What are you looking
Yes.
for? I say I will do MRI. What is better?
Sir, to delineate the lymph nodes, CT is apparently more sensitive, but to see the entire biliary tree, MRI is better. Then we
Anatomy
can
of the biliary tree
anatomy
with, if there is obstruction, yes, definitely
obstruction,
MRI better.
MRI is better.
Then what else?
Sir, and while we are doing a contrast and CT scan of the abdomen, we can, along with it, we can also do a CT scan of the thorax to stage to look
Okay,
for any
but what?
metastasis.
Let us talk about the local staging first. So CT thorax, you are excluding lung mets. We can exclude
Yes, sir.
lung mets by CMRI also. MRI of the lung can also be done.
Yes, sir. Yes, sir.
But what about the local staging? Is there any advantage of MRI over CT?
Sir, MRI will give a better soft tissue delineation of the spread.
Yes. So what information specifically are we looking for?
Sir, if
Minor
the fat
infiltration of
plane,
the liver, small or
small,
minor infiltration of the liver will be better appreciated on MRI, not on CT.
yes,
Small liver mets will be better appreciated on MRI, not on CT. Less than 1 centimeter size lesions of the liver, metastatic lesions, are not picked up very well on the CT, especially if the liver is already fatty. Fatty
fatty
liver,
liver.
smaller lesions will not be picked up less than 1 centimeter. But MRI, especially with DFI, diffusion weight, DWI, sorry, not DFI, DWI, diffusion
DW.
weighted imaging is very good. Anything
Yes, sir.
else? Involvement of the vasculature.
Vasculature.
If it is locally advanced, as it seems to be in your case, it is very likely that the portal structures are involved somewhat, more or less. Maybe not presenting with jaundice, but there may be IHBRD, minimal IHBRD already because of compression of the common hepatic duct, because of involvement of the portal vein and all. So common hepatic duct or common bile duct you can sacrifice. but sacrificing the portal vein is not feasible.
No,
So
no,
you have to assess that very properly. Otherwise, you will get a margin positive. You will see
yes.
that it is averting the portal vein or slightly infiltrating the portal vein, and you will have to cut away from that and leave tumor behind. Entire operation will be useless. Unnecessarily, the patient will undergo operation. So assessment is important. So the MRI is much better than CT. Diffusion weighted imaging MRI, contrast MRI will give you a better delineation. So all the points I'm saying are better in MRI, but you are doing a CT scan. I'm also doing a CT scan. Why is that? So there must be some points against also.
So the lymph nodes are better appreciated. No,
If not, MRI also, contrast MRI will be good enough. CMRI will be equal for CT and MRI. What are the disadvantages? Strong disadvantages.
sir, prolonged time
Data acquisition
in
time,
MRI,
yes. So respiratory artifacts, movement artifacts are
respiratory
important.
artifacts,
Then
uh,
it is more
and
expensive, but still
more
not widely
expensive. Yes,
available.
yes,
So does your hospital have MRI?
yes, sir.
Okay, good. That's good. But many hospitals are there which have CT scan, but we still don't have a MRI machine. Especially it has to be at least a 1.5 Tesla, preferably
Yes.
a 3 Tesla machine. So may not be available everywhere. Okay. So that is so. But if you say I will do a contrast enhanced triphasic CT scan of the abdomen and thorax, it is absolutely fair. Nothing wrong with that. But you should also know specific cases where MRI might be better. So if there is
Yeah.
jaundice, then probably I would say that because the patient also has jaundice, I need a detailed outline of the biliary tree. I will go for contrast enhanced MRI of the whole abdomen with MRC. So in
Yes.
one stroke, I will finish it off because I need to know the obstruction of the biliary tree to assess, and I need to know the vasculature. If it has involved the common hepatic duct, there is a very high chance that it is very close to the portal vein also, and I need to know that before I consider surgery. Okay, so I will
Yes.
prefer MRI over CT in that case. In this case, there is no jaundice. I might be happy with CT scan. Anything else that you will do?
Sir, I'll do the routine examinations.
Not routine,
Any,
not
any
routine.
role for tumor marker?
The sir
Yes,
is
sir.
giving you an
We can do a CEA and
can
CA
do. We will
99.
do. Not
We will
can do. We
we
will
will
do.
do a CEA and CA 99
What
CA
does
studies.
CA
99
stand
is
for?
very high.
Hmm.
CA 99 is very high. What is the implication? Maybe CA 99 is more than 100.
Sir, it is suggestive of a more advanced disease.
Advanced disease.
The
Yes.
Yes,
disease burden. So
disease
if
one.
imaging is not showing you a regional metastasis or in, but the CA 19.9 is 500, 600, you take it for granted that there is disease elsewhere. There will be a very high chance that you will pick up occult disease, which is not being picked up on imaging. Okay.
Yes, sir.
What does CA stand for? CA 19.9. What is CA?
Sir, sir, forgot, sir.
Carbohydrate.
Carbohydrate
Oh,
antigen.
carbohydrate and
Okay.
carbohydrate.
No problem.
Yes.
So you will do CA 19.9. Don't say we can do. We will do CA
Yes.
19.9 and routine investigations for assessing the fitness of the patient. So
Yes,
you
sir.
have done that and the report has come. Obviously, the mass is there. You can feel the mass. So there is some amount of involvement of the liver.
Yes, sir.
But there is no involvement of the portal structures. There are a few lymph nodes in the HDL. In the cystic lymph node appears enlarged, and there are one or two enlarged lymph nodes along the HDL.
Yes,
And
sir.
you've got a CT thorax done, which is not showing any lung metastasis. Anything else you want to see? At 19.9, like sir said, is more than 100. Now what?
Dr. Rishi has asked one question. Any role
Yes.
for PET CT as a primary
No,
imaging?
no.
No,
For
sir.
upfront
No, sir.
staging, the standard recommendation is
No,
not
sir.
PET CT.
Yes.
You would only use it as a problem-solving tool. Suppose there is an
Yes.
atypical lymph node somewhere, which is slightly enlarged in a non-regional setting, and you are suspecting, or maybe the CT scan has picked up a adrenal lesion, which is equivocal, 3 centimeter, 3.5 centimeter, and you are worried whether it is metastatic or not, and you want a problem-solving approach, then you could consider doing a PET CT scan. Otherwise, for routine upfront staging of gallbladder cancer, PET CT
Yes.
scan is not needed.
Because most are not PET avid.
Not mucinous type of cancers are not very PET avid. And plus, PET can give rise to some confusions also. False positives can also be there. So then you are worried.
Fine. Consider this as a operable disease, but CA 99 is high. Imaging
Now
wise,
what?
likely to be operable disease, but your CA 99 report says it is more than 100.
Anything else
Sir,
that you would like to do?
uh,
What is the treatment for operable gallbladder, CA gallbladder?
sir, for a operable gallbladder, we will go for a radical cholecystectomy.
Open radical
Yes,
cholecystectomy, or maybe a laparoscopic radical
Luck,
cholecystectomy.
Lucknow
So,
approach preferred.
but CA 19.9 is high. So, what will you do differently?
Um, Sir, we can go for, sir, neoadjuvant chemotherapy and then
No, no, no,
Directly.
no, no, no,
In
no.
an otherwise
mm,
operable case, on
Otherwise,
imaging
operable
it is
is not
operable.
your.
CA 19.9 is high. Any simple thing. Before doing the open incision, what can you do?
sir, we can do a diagnostic laparoscopy
Yes,
to see
staging
the
laparoscopy.
diagnostic laparoscopy.
Because
Yes, sir.
sometimes small peritoneal mets, you must have seen 4
Yes, sir.
millimeter, 5 millimeter, 6 millimeter
Yes, sir.
spots in the upper
Yeah.
abdomen around the diaphragm peritoneum. That cannot be picked up even on an MRI. Unless it's a very good quality MRI done by a very good radiologist, they will not pick it up. And CT will definitely not pick it up. There may
Yes,
be
sir. Sorry,
small
sir.
few dots on the
Taking it.
omentum. So then you made a big incision. What is the incision that you make for a CA gallbladder? It's an extended subcostal or a
Yes, sir.
bilateral subcostal, rooftop incision. It's a
Yes.
big incision. And then you open and then you see there are multiple small mets. It's a wasted incision. So you just do a laparoscopy, especially if the CA 19.9 is high and the imaging is also studying that the primary is slightly enlarged. You must consider a staging laparoscopy, diagnostic. It does not add much time or mortality. Everyone has a laparoscope now. Okay.
Yes.
So that has to be done. So you have done the laparoscopy and there is no obvious peritoneal mets. There is no obvious small liver mets that the lesion that the CT has not picked up. Seems to be operable. Now what? What is the operation going to do? Some amount of liver is involved.
Sir, first of all, we need to do the Cocker's maneuver and check the uh, aortocaval nodes. If
Okay.
if it is
And
not involved, then we will proceed for the operation. If it is involved, we need to abort. If it is not involved,
How do you know? How do you know outer wall node is involved or not? What is the recommendation?
sir, recommendation is we need to take send it for frozen section biopsy.
Because by palpation, it is difficult to uh, establish is a metastatic or not.
Yes, sir. We have to send it for frozen section biopsies.
so what else? What else? Then what?
Um, so then,
Quickly, we are running out of time.
sorry, sir. Sir, if then we need to, if it is not involved, we can go for the Lucknow approach uh, of
In this case, Lucknow approach. This is clearly a large mass with
Yes,
obvious
yes.
infiltration of the liver. Why the Lucknow approach? Lucknow approach is when there is
for
what you
1B.
said,
Yes.
anticipated minimal wall thickening, asymmetric wall
Yes.
thickening. You are not sure still whether it is a mass or it is just chronic cholecystitis. Even on opening up, you can feel there are lots of stones. It is packed with stones. The gallbladder wall seems slightly thick. You will see many cases like that. It
Yeah.
is
Yes.
not possible to appreciate on palpation whether it is actually a CA or it is just chronic cholecystitis. Early disease. You are lucky enough to have got it, but you suspect that it can be early disease. Then you use the Lucknow approach. Before, if you say the Lucknow approach, I say I will just do a simple cholecystectomy and send it for frozen section. Why not? Why do I have to do the Lucknow approach? Lucknow approach is in addition to simple cholecystectomy, we are taking
One
at least a
centimeter.
1 centimeter or 1.5 centimeter wedge of the adjacent liver bed and then
Yeah.
sending for frozen section. That is purely for a small thickening of the gallbladder wall. You are not sure whether it is a CA or not,
Yes.
even after imaging. Why do you need to do that? Why not just do a simple cholecystectomy and send it for frozen section?
Sir, because in simple cholecystectomy, we are when we dissect the gallbladder from the liver bed, we might leave the serosal parts of the serosal layer
There
and
is no serosa on the liver bed side. On the liver bed side, the gallbladder serosa is getting reflected onto the Gleasonian capsule. The
mm,
gallbladder bed does not have serosa. So no
uh,
question of leaving behind serosa.
uh, sir, uh,
The dissemination of the gallbladder occurs in the perimuscular plane. The muscle coat of the gallbladder is very thin. Unlike the bowel, the gallbladder wall is a very thin
yes,
muscle
sir.
coat. It is easily penetrated. From
Yes.
T1B to T2, T1B to T2 is very easy. It goes quickly as the muscle coat, and then it spreads in the perimuscular plane. And that is
Yeah.
the plane where you dissect it off from the liver. So if it is already T2 and it is very difficult to distinguish T2, then you will cause spillage of those tumor cells, not leave behind. You will cause a propensity for the tumor cells to be spilled into the peritoneum, and a potentially curable case will become incurable. So for early wall thickening, when you are not sure whether it is actually CA or not, but you want to remove the gallbladder for frozen section, better to take some liver along with it. May not be formal 2 centimeter, but at least a 1 centimeter wedge of liver. That way, if it is early and it is in the perimuscular plane, then you are not spilling, causing spillage of the tumor in that plane by going in that plane like you would do in a simple cholecystectomy. Right? So that is the Lucknow approach, anticipatory cholecystectomy. Anticipating that it might be CA and taking some liver along with the gallbladder, not just the gallbladder.
Yeah.
Okay. But in this case, in your case, there is a frank mass. There is infiltration into the liver of the CT scan. There is no doubt. Here, why would you go for anticipatory?
No, no.
Here,
You can go for
radical
radical.
cholecystectomy.
Radical on clinical exam and radical finding.
It is clearly CA. There are nodes enlarged. So what will you do?
Sir, we
What is radical
will,
cholecystectomy?
sir, for this, we will go for a radical cholecystectomy, that is the cholecystectomy along with preferably extended right hepatectomy and
All
lymphadenectomy.
cases
No,
extended
not
right
all cases.
hepatectomy.
No, sir.
If
Oh,
there is gross involvement, then
No,
only
here
can.
we will take segments of 4B and 5.
you say I will take segment 4B and 5. I say I will remove a 2 centimeter wedge. Is there any evidence that removal of the segment 4B or 5 is better as compared to taking a 2 centimeter wedge, provided I get a negative margin?
No, sir.
Then why will you do? Is there any evidence for that?
No, sir.
You check this paper by Shivendra Singh from an Indian author. Shivendra Singh's paper published in Annals of Surgery 2025, randomized control trial. Segment 4B5 excision versus 2 centimeter wedge excision in early carcinoma gallbladder. And where obviously margin was negative. If the infiltration into the liver is 2 centimeters, then you cannot take 2 centimeter wedge. But suppose there is minimal infiltration or up to 1 centimeter infiltration or no infiltration, but you are still doing a radical cholecystectomy. In that case, a 2 centimeter wedge excision was found to be as good as formal segment 4B5 excision in terms of DFI, in terms of overall survival, and the formal 4B5 excision was associated with longer operating time and more blood loss. So they concluded that a 2 centimeter wedge is fine, provided you are getting negative margins and you're removing all the disease. That you should have an idea from the CT scan or the MRI how much of the infiltration of the liver is there. Okay. So there is no need to do. Now you have evidence, randomized evidence. There is a meta-analysis, 2023 meta-analysis of studies which has also concluded same. I think that is from Korean people. Okay. Segment 4B5 versus 2 centimeter wedge comparison, meta-analysis, published in 2023. That also showed no difference in DFI or overall survival between the two types of treatment. So a 2 centimeter wedge dissection is enough. Okay. Suppose there is a neck mass and it is infiltrating into the porta, causing infiltration of a CPD. Then what would you do? What operation would you need to do?
Sir, we need to resect the common hepatic and the common bile duct,
And
and
in the
then
process, what will happen? If it has gone from the gallbladder and involved the common hepatic duct, what is likely to have happened? What about the right hepatic duct, right hepatic artery?
so there might be involvement of the right
It's
hepatic
almost
duct.
invariably involved. If it has gone and involved
Yes,
the
sir.
common hepatic duct, the right hepatic artery and duct will have been taken. You
Yes,
will
sir.
not get a margin there. So what are
No,
you
sir.
going to do? What operation will be done now?
Sir, in this case, we will
Yes,
do a
extended, right
extended
Extended,
right
not
hepatic.
only
right
right.
trisection. So what are the segments being removed?
Uh, Sir, segments 4, the whole segment 4 and the right lobe.
What are the segments on the right lobe? Quickly.
Uh, Sir, 5, 6, 7, and 8.
Very good. So 4, 5, 6, 7, 8 will go. So what will be
Yes,
left?
sir.
Just
Uh,
1, 2, 3.
1, 2, and 3,
So you
and
understand the concept of FLR, future liver remnant?
yes, sir. Yes, sir.
So how
Yes,
will
sir.
you decide whether this 1, 2, 3 is enough or not pre-op before going into this operation? Otherwise, patient will end up in liver failure if FLR is
Uh,
not adequate.
yes, sir. We need 25 to 30% of the
So how will you
functioning liver.
decide that? How will you decide it? Is there a function that is
Sir,
25 to 30% is just the physical amount.
yes,
Physical
sir.
amount may not always correlate with physiological function. So is there
Yes,
any
sir.
way of testing physiological function in case of major hepatic resections?
Sir, we can do elastography, fibroscan, and there are softwares to map the
Hepatic
um,
volumetric.
Elastography can be done. Anything else? Something simpler?
sir, fibroscan.
ICG retention test. Are you aware
Yes,
of
sir.
ICG
ICG.
retention
Yes, sir.
test?
Yes, sir.
What is that?
Sir, if more than 15% of the dye is retained after 15 minutes of giving the
10%.
dye.
If more than 10% is retained, it is worrisome. Ideally, at 15 minutes after injecting the ICG, less than 10% of the dye should be retained.
10%.
Okay,
Yes.
so ICG retention test is a simple test to assess for hepatocyte function, actual physiological function, not just
Yes.
the volume. Sometimes volume may be there, but it might be fatty liver, it might be post-chemotherapy liver, it might be cirrhotic liver, and the liver
Yes.
function may not be good, although volume is there. So
Yes,
to
sir.
see hepatocyte function, ICG retention test is very good. So suppose you're not doing all that, you're not doing a trisectionectomy, you're just doing a simple 2 centimeter wedge for these cases, and you're doing a lymphadenectomy, right?
Yes, sir.
So what will you tell the anesthetist before starting the operation? What antibiotic will you give? Will you give prophylactic antibiotic or systematic antibiotic? What is prophylactic antibiotic? Quickly.
Sir, in case of biliary involvement, we can use
There is no biliary
cefoperazone.
involvement. We are just doing rat coli with 2 centimeter wedge.
Uh, Sir, cefoperazone and sulbactam is preferred
Okay, fair
in
enough.
when.
Fair enough. Yes, second generation cephalosporin is a good option.
Yes, sir.
In fact, third generation cephalosporin is also good. Cephalosporin is probably third generation. Then
And
what will you tell the anesthesiologist? You're removing a 2 centimeter wedge. No, you said I will remove segment 4B or 5. You have to tell something to the anesthesiologist.
so you have to maintain a lower blood pressure
Not
for
blood pressure, lower
the right
central venous pressure, Baba. Low
central venous
CVP,
pressure.
absolutely low CVP,
Low
as
CVP.
near zero as possible. So they should
Yes.
restrict fluid intake and they should, if necessary, give Lasix to reduce
Yes.
the preload. Okay.
Yes.
Then what else? What do you do? So you have done the lymphadenectomy. Now you have dissected the calloids, right? And
Yes,
you have
sir.
ligated the cystic artery and cystic duct. You have sent the cystic duct margin for
Frozen section.
frozen section. To
Yes.
confirm that, you've got it negative. Now you're going to start the actual liver resection. What are you going to do?
We have already done the portal dissection. So
Yes, sir.
Will you do something to help you to resect the liver?
we have done last day only. We have done 1 week back.
Then you
Yes,
must
sir.
say. These
I
are the
asked
questions that a
sister,
surgeon should know. No use talking about new adjuvant therapy and adjuvant therapy. It is not your job to know adjuvant therapy.
you only assisted that day. What you
What will
did
we do?
with the portal vein and the hepatic artery?
Come on, sir is telling you all the answers. Come on. Pringles maneuver, surgical Pringles maneuver, you will occlude them temporarily.
Yes,
Yeah.
sir.
To reduce the blood flow. It will control the inflow. If there is a major resection, you want to resect formally segment 4B for you want to for other tumor also, any hepatic resection, you might need to control the outflow also. So before that, you might want to mobilize the liver a little. How do you mobilize the liver? So that it is more accessible. Otherwise liver is below the costal arch. It is difficult to get to the top of the liver. So if you mobilize it somewhat, then it comes down. Then it is easier to handle. The bleeding and all can be controlled better. You can take sutures. How do you mobilize the liver? How do you do Pringles? How much time will you do Pringles? Quickly. So there are many options. You can occlude for 10 minutes and
10
let's
minutes.
leave it for 5 minutes. So 10 minutes you occlude, you tell the anesthetist to watch the time, and then you start your resection. You will see that the blood loss is much less. And then when it is 7 or 8 minutes, anesthetist will warn you. You will achieve hemostasis, and at 10 minutes, you will take off the clamp. Why do you need to take off the clamp? I keep the clamp on for 30 minutes, 25 minutes. If I keep it clamped, I will manage a 2 centimeter wedge. Why do I need to take it off at 10 minutes?
Sir, it will cause ischemic.
Ischemic? What
Sorry,
ischemia? To the
it was
liver?
sorry.
No, liver, you do liver transplant. The ischemia time is much more than 20 minutes in that case.
Sir, prolonged ischemia time might predispose to reperfusion injury.
Of the liver? No, not 20 minutes, 25 minutes. It will not cause any ischemia. 25 minutes will not cause ischemia, I'm telling you.
Yes, sir.
What is the main problem? More important problem. Not ischemia to the liver. There will be bowel congestion. Entire bowel blood flow is coming to the portal vein, Baba.
Yes, sir.
So
Yes.
gut edema will be there. You will not be able to close the abdomen if you keep it calm for 25 minutes. Gut will suffer, not liver. Liver will not suffer. Liver has got large reserves. Okay. So
Yes, sir.
therefore, you have to do intermittent clamp. After clamping for some time, then you have to let go and allow the gut to get decongested. Okay. And suppose you are doing formal 4B5, what do you have to do?
So there are some segmental vessels coming from the
Sir,
Glissonian
from
pedicle, which is
the
entering
so the portal vein and the hepatic
artery.
artery.
Yes. So you have to dissect them out.
Yes,
You
sir.
go to the sub branch, and then you have to ligate them individually. Sometimes you can isolate them and inject ICG into those veins selectively, and then see those segments staining, and that will help you to do a anatomical dissection. Okay.
Yes,
So
sir.
now it comes out to be node positive. Final history: you have done a radical cholecystectomy. Patient has recovered post-op. What is the histopath is node positive? What now?
Sir, we need to go for adjuvant chemotherapy
Adjuvant
with
chemotherapy. Okay.
with
Suppose it is inoperable. Suppose on staging you find that the portal vein and all are encased, and the patient has got jaundice. Then what?
sir, if it is inoperable according to the ABC2 trial, we can give we will go for palliation and chemotherapy with gemcitabine and cisplatin, sir.
Before giving chemotherapy, the patient has got jaundice.
Sir, we need to do some drainage procedures,
Drainage,
preferably.
biliary drainage. With high
Yes, sir.
level of jaundice, nobody will give chemotherapy. Okay.
No, sir.
Then you have to use PTBD or
PTBD, yes, sir.
ERCP with stenting if possible.
Yes,
Okay.
sir.
Sir, what else to ask?
name.
Time is up.
Time is up. Yes. Thank you. Thank you.
Okay.
Thank you. Well discussed. Very good. This is enough for DNB and MSc.
More than enough. More. He has done well. The surgical
Okay.
part, a little more you should
Yes, sir. Yes,
concentrate
sir.
on.
I was sorry, sir.
Thank you, Tom, for taking the class.
No,
Very good. Thank you.
thank you, sir.
Thank you, sir.
Thank
Bye.
you. Thank you.
Thank you, sir.